I'm going to talk first, and our session's called Survive and Thrive Post-Lung Transplant, Part 1. There's a Part 2, I guess, later on today or tomorrow. But I think we'd like to emphasize that thrive part, not just surviving after a lung transplant, but really the goal after transplantation is really to give people an improved quality of life, not just improve kind of survival time. But you do have to prepare yourself. There are a number of things that, that potential complications and things, and it's not always an easy road. And so we like people to be informed when they're making that decision to go into lung transplant. So here's my disclosures. I'm a speaker for United Therapeutics, and I've been a speaker for Ultivant in the past, and I've done advisory boards for those companies. So this is what we're going to cover today. But let's just jump right into it. So one thing I wanted to talk about, post-transplant can be a little bit overwhelming. Patients with pulmonary fibrosis are used to taking some medications usually, but a lot of times it's an antifibrotic. It's not this overwhelming medical burden that some of our patients with like pulmonary arterial hypertension or cystic fibrosis, where they really have these intensive medical regimens going into transplant. Pulmonary fibrosis patients aren't necessarily geared up for that in the same way. And certainly, not to minimize it, I mean that you still have the burden of oxygen, potentially pulmonary hypertension medications, now antifibrotics, immunosuppression, depending on your underlying lung disease, pulmonary rehab, and those things. But sometimes patients are surprised by the sheer volume of pills that they have to take. And in general, you get immunosuppression, and it's usually 3 different medications up front. Not everybody can tolerate three medications. Sometimes people end up on 2, and there's various ones to choose from. And then prophylactic medications to prevent opportunistic infections, at least early on. And then all your other stuff too. You may need, reflux medicine, cholesterol medicine, baby aspirin for heart disease, etc. And so it adds up to a lot of pills. Why so many pills? Well, we're trying to walk this tightrope all the time. Dr. Nathan, who spoke earlier, has been my boss for, I've known him since I was a fellow, many years ago. He's always talks about walking the tightrope of transplant. So you're trying to balance these risks of infection versus rejection, low cell counts versus rejection. And it's oftentimes a difficult balance to strike, and it's a little bit different for every patient, and so that's why we're constantly adjusting your medical regimen, and it can change over time. And early on, patients require more immune suppression, and so that early period after transplant is really critical, where you're at the highest risk for infection because you're on more medication, but you're also at the highest risk for rejection. That's why we kind of watch you like a hawk and frequent clinic visits early on, and then over time, that burden lessens a bit. In addition, by using multiple medications but lower doses or moderate doses of those medications, you can decrease the number of side effects that any individual medication might have. So what are some of the common medications and their typical issues? I think most people have seen steroids at some point in their life where they're comfortable. So what I mean by steroids is corticosteroids, things like, prednisone, prednisolone, Decadron, Salumedrol, etc. And so I think, some irritability, insomnia, weight gain is a biggie that patients complain about, high blood sugars, and oftentimes the development of diabetes can be caused by use of steroids, and then can cause weakening of your bones. Tacrolimus or cyclosporin are other, they're what we call calcineurin inhibitors, and those can cause kidney issues. They can cause electrolyte issues. Most of our patients end up on magnesium replacement because of that. Some patients, particularly at higher doses, end up with like a kind of a fine resting tremor, which can be relatively annoying to disabling in some cases, and there's different things to do for that. You can develop peripheral neuropathy, meaning like kind of numbness and tingling in your hands and feet with these medications, and there's a bunch of other issues that tacrolimus and cyclosporin can cause much less commonly, but I tried to highlight some of the more common things you'll see. And because of those issues, you need to monitor drug levels and kidney function. Mycophenolate, there's also another medication called azathioprine we use less commonly now. That's kind of like mycophenolate's cousin. They're similar medications, but these are additional immune suppressing medications, and you have to monitor. You can decrease blood counts, so you can cause low white blood cell count, anemia, low platelet count. Probably the bigger complaint we get is nausea or kind of stomach upset. And these medications require monitoring of blood counts and liver function. Some of the valacyclovir is a medication that we use to prevent cytomegalovirus infection, and that can cause low white blood cell counts as well, so something to watch out for. And then rapamycin is a medicine that we can add later on in the transplant course. A lot of times if the Prograf or tacrolimus is causing issues with your kidneys, it's an alternative to that, or for patients that maybe have skin cancers pop up, things like that, you can use it, and it has a lower risk of cancer associated with it, but can cause wound healing issues, edema, low blood counts, and also requires monitoring of drug levels, et cetera. I found this resource while I was making this talk. It's from the UNOS Transplant Living website, and it had a lot of good information for patients about, what the medications after transplant are for, and what are the common side effects, and sort of monitoring strategies. And so I thought it might be useful, so I threw it in there. They asked me to specifically talk about drug-drug interactions, and a lot of times if you look things up, there are drug-drug interactions with these medications that we use commonly, but many of them aren't clinically relevant. And so there are a few that are noted to be relevant. So a lot of times we'll use what they call azoles, so things like voriconazole or posaconazole, which are antifungal medications, and they have a lot of drug interactions. They can increase your levels of tacrolimus or cyclosporin, and so we have to monitor for that. We're cognizant of that when we're starting them. There's also interact with some of the blood thinners that we use, and so have to be cautious with that. Some of the medications that you might be on for heart failure medications are like spironolactone, can cause high potassium levels in combination with these other medicines. Lipitor, atorvastatin, and cyclosporin together can cause muscle breakdown, so that's something to be cognizant of. And nifedipine, which is a common blood pressure medication, and tacrolimus can cause increased drug levels or a gum issue called gingival hyperplasia. One big thing that they always harp on, I think it's not something I've ever seen commonly, I feel like this is the one thing that sticks from education, is grapefruit increases a lot of our drug levels, and so I put a grapefruit on there. We also preach to steer clear of a lot of the over-the-counter pain medications. So if you get a fever, Tylenol is okay. If you have kind of minor aches and pains, Tylenol is okay. But NSAIDs, non-steroidal anti-inflammatory drugs like Aleve or naproxen, Motrin or ibuprofen can cause issues with your kidneys when combined with these transplant medications, and so you want to avoid those. I think rather than focusing on every single drug interaction and all these different names, because it's like learning a foreign language, I think always ask your transplant team before starting a new medication. And even if you're seeing, say, your primary care doctor or another specialist, I would run those things back by your transplant team. Like if your cardiologist says, I want to start this medication, it's good for your heart, it's probably worth just checking with your transplant team, because they're in tune to these drug-drug interactions that transplant medications have, whereas some other physicians might not be as familiar with those typical things. I would also mention that herbal supplements, you never know what you're going to get, but they do have real side effects, and so I'd be cautious with just taking lots of herbal supplements or over-the-counter medications without thinking about it, because you can get real side effects from those. So what kind of other things should we preach in terms of a healthy lifestyle post-transplant? A lot of it is the same stuff that anybody that goes to the doctor would hear. You should, eat a healthy diet, maintain a healthy body weight, get regular exercise, stay up to date on your vaccinations. There are some vaccinations that are live vaccines, and your transplant team can tell you what those are. But in general, things like the flu shot, pneumonia vaccines, the newer shingles vaccine, those are all things that are typically recommended for transplant patients. And there's a lot of instructions about specifics for diet, so a lot of things to avoid infectious complications from food. So don't eat dated leftovers. There's some bacterial infections, like with fried rice and things that's left around that you can get. Don't eat raw or undercooked foods like seafood, meats, raw or undercooked eggs. Foods with raw eggs, like cookie dough, unfortunately, is out after transplant. I feel like They should warn you about that before transplant, maybe. Unpasteurized milk and cheese, bean and alfalfa sprouts. And then alcohol is listed on there. I think if you take a hard line on this, you would say no drinking after transplant. That's the sort of the party line for most transplant programs. I'd say, in general, like if a patient wants to have one drink on their birthday or something like special occasion, things like that, most programs will look the other way. But you certainly, moderation. One thing I didn't talk about here, all different programs have different views about medical marijuana. I know that's something that's increasingly used for pain. You should never smoke anything after a lung transplant, but if they're interested in using medical marijuana, it's something that you should discuss with your individual program, because a lot of them have different rules about that. And like, for instance, our program doesn't permit it, and it's a sort of a violation of your contract. But some other programs are a little more forgiving about that. Other things, avoid gardening and digging in the dirt. There's some fungal infections and things that you can get from that, and some unusual bacterial infections. Cat boxes are out, so if you have a cat, that's okay. Your partner's got to clean the cat box for you, though, so not the worst thing that could happen to you. I would say avoid large crowds, or if you have to be in large crowds, mask up. I think that's probably good advice for most people with lung disease or after transplant. Buffets are probably not a good idea, just because people it's like salad bars, buffets, people like, coughing, sneezing, touching the food, put you at risk of infections. Again, I mentioned no smoking ever of any kind. Make sure you're wearing your sunscreen. You'd be surprised at some of the issues we see with skin cancers, particularly in white men after transplant. You can get very kind of aggressive skin cancers, particularly with if we use some of the antifungals and CellCept together, it puts patients at substantial risk. Pay attention to your body. If you think something's wrong, then there's a chance that there is, and it's worth reporting to your team and at least letting them know about it. And you should be checking your vitals every day. And a lot of programs issue a home spirometer, and you can do spirometry readings. And so sometimes things that might not seem like a big deal, like a low-grade fever, you just feel a little bit off, could be maybe signs of rejection or signs of an early infection. And transplant patients can get sick pretty quickly. So what are some of the issues with complications after lung transplant? There's over 70,000 have been performed worldwide. I gave a talk yesterday. The median survival is improving, but lung transplant, because of the risk of chronic lung allograft dysfunction, and patients tend not to live as long as other solid organ transplants, and there's both early and late complications you can see. So this kind of breaks down, the increasing number of transplants that's done, more bilaterals than singles. The bilaterals are purple, singles are in green there. And then this is the median survival. So for double lung transplant, it's about 7.8 years. Conditional means if you live a year, then the average life expectancy goes up to 10.2 years. For singles, you can see not quite as good. This is showing that over the sort of eras, we haven't made a ton of improvements, so kind of marginal improvement over time, but working on it. And so, there's some disparity. Like most of the improvements we've made is in that first kind of year after, like we're better at taking care of patients in the early post-operative period, but like chronic lung issues we haven't really figured out quite yet. So what are some of these early complications? Very early after transplant, you get something called primary graft dysfunction, and that's like you get kind of this like leak of the vessels in the lungs that can cause a high need for oxygen. It's fairly common in lesser degrees, and it's actually fairly common. Even grade 3 can be there and then kind of go away, although some patients get severe primary graft dysfunction that's problematic. This patient that you see here, has kind of has a fair amount of PGD, which is that fuzziness in their lungs, and then their lungs kind of clear over time, and their oxygen levels improve. You can also see surgical complications. You can get bleeding into the space between the lung and the chest wall. That's a fairly common but correctable. Vascular complications where the surgeon sews in the pulmonary artery or pulmonary vein are relatively rare, and they check for that closely in the operating room. Less than 5% of patients get those. You can get infections of your surgical sites, and so we're constantly monitoring for that. Issues where you develop fluid in the space between the lung and the chest wall, but those are relatively uncommon. You can get issues with the nerve if it gets sort of a thermal injury or stretch, can sometimes cause some dysfunction for a period of time, which can improve most of the time. Sometimes it doesn't. And then you can get rarely airway issues where they sew the new lung in, what they call a dehiscence, where that suture line kind of breaks down, and that can be a big problem if it happens. Later on, you can sometimes have narrowing of that area too, and that can cause some degree of shortness of breath. There's a number of other early complications we see in the hospital. You name an organ system, there's different problems that you can see with it. People can be confused. A lot of people are weak and need a lot of rehab after transplant. That's relatively common. Cardiovascular issues, so funny heart rhythms happen probably a third of patients. A lot of patients arrive in the ICU with a little bit of shock from cardiopulmonary bypass and just the surgery itself. You can see issues with diarrhea very commonly just from the medications and sometimes tube feeds in the hospital, or the stomach not working and not kind of moving stuff downstream, and people feel nauseous. Kidney injury. Some patients transiently need dialysis. Some patients, if things go, not ideally, can end up on dialysis permanently. It's less common, but it is a risk. Diabetes is a relatively common thing you see early on, particularly when you're in higher doses of steroids, and lots of issues with low white counts, et cetera. Infections common too, and it's generally treatable, and your infections vary from the time from transplant. So early on, you're thinking things like surgical site infections or line infections, urinary tract infections. As you go on, like later into the transplant course, those infections change over time. Most transplant programs have transplant infectious disease doctors that are infectious disease doctors that are focused specifically on transplant patients and know about these particular issues. Other issues, you can see acute rejection. There's different forms of it. About a third of patients get treated for rejection in the first year, so it's relatively common, but it is very reversible with kind of steroid dosing in most cases. It does result, 4% of the deaths that occur within 30 days of transplant happen to be from transplant or from rejection, but again, relatively uncommon. And it's most likely in the first 6 months after transplant, but I've seen it, much later on. It can still occur. Again, there's two forms: acute cellular rejection, which is the T cells kind of attacking and causing inflammation in the blood vessels. You can also form antibodies that attack your transplanted lung. They recognize that it's not your body. And so the treatment's a little bit different. It's usually steroids or another agent that wipes out the T lymphocytes for acute cellular rejection, whereas antibody-mediated rejection requires treatments to clean the blood and stop the B cells from producing more of those antibodies. CLAD is the Achilles heel of lung transplant. This is the reason patients don't live as long as other organ transplants. And so it's like the lung loses quality over time. There's different forms of it. There's one called BOS it's almost like you develop emphysema. And there's another form called RAS, which is almost like developing pulmonary fibrosis. So, the treatments that we have are really not adequate. And so I think, the transplant community has been trying to figure this out for years. We're hoping that, improved and earlier diagnosis of treatment of acute rejection will prevent development of CLAD. There's some work on different therapies for CLAD, but as it stands right now, not great treatments available. And again, 40% of deaths after the first year of transplant are from CLAD. BOS makes up about 70% of the cases, and again, lack of effective treatments.
Could you explain some of those CLAD and BOS?
CLAD is chronic lung allograft dysfunction, and so they used to say sort of chronic rejection. We don't know for a fact that it's rejection, but it is like dysfunction of the transplanted lung. BOS is bronchiolitis obliterans syndrome, and that's more like an obstructive kind of lung disease, similar to COPD or emphysema that patients can get. There's a number of other different kind of complications you can get over time. You can, again, infections, hypertension, funny heart rhythms, diabetes, kidney issues, kind of issues with stomach emptying, but The transplant programs know to look for these things and will be monitoring for these issues. And so I just kind of highlighted some of the more common ones. So diabetes, coronary artery disease, chronic kidney disease, bowel ischemia and perforation we sometimes see at a higher incidence than you'd expect. Low blood count issues. There's something called post-transplant lymphoproliferative disorder, skin cancers. And then I think anxiety, mood disorders I think are not uncommon after a transplant. So again, I think we try to coach people. It's like you're trading for a new disease. It's not like getting the oil changed in your car. When you take on a transplant, you do take on a lot of work and maintenance, a lot of medications, a lot of doctor visits, a lot of interaction with your team. But can, if it goes well, it really holds the potential for lengthening your lifespan and improving your quality of life. And this is actually he was a policeman in DC that had kind of sudden onset lung failure, ended up on ECMO, and this is him exercising at our program after transplant. And he looks like a bodybuilder. I mean, he did before transplant, he got back to that afterwards.
Thanks,
Sure.
Chris. Thanks to the PFF for asking me to talk. There's going to be a lot of overlap between what Dr. King spoke and I'm going to talk. So at the end of this talk, you guys should all be experts. We'll have a question and answer. So who knows what this is? So Dr. King showed you tightrope walking. He went to the circus. I went straight to the classics. Right. So this is from Homer's Odyssey, right? So this is the when Ulysses goes away and then tries to get back to the Strait of Messina. He has to deal with the devil on the deep sea, or Scylla and Charybdis, right? So Scylla is the multi-headed monster trying to eat some of his sailors. On the other side, Charybdis is the whirlpool. So if he's going to hit the whirlpool, he's going to sink, and he's going to the other side, he's going to hit the rocks or get eaten. But that's good news for people who have forgotten it. He did make it. He made through it, right? So what's in it for us? So that's what this is, right? So in post-lung transplant, this is what it is. This is something between infection and rejection, and you're trying to navigate between the two without getting caught in one end or the other, too much infection or too much rejection. Right. So why is it, as Dr. King already said, immunosuppression is much, much higher in lung transplant than other organ transplants. We always look at the liver people and say, oh my God, they get a liver and they do well, and 2 years later they are very little immunosuppression, and that's okay. In lung, it's much, much more difficult. It's a large organ, big surgery, and all that. And we talked about infections, and there's some suggestion that chronic or recurrent infections, viral infections, provoke rejection. So not only just rejection from direct rejection's sake, but all these infections can set you up for rejection. So trying to avoid those is important. So prevention is sort of way more useful and important than trying to figure out a problem after it happens. So what can you do in terms of prevention? And it starts way before transplant and starts in pre-transplant. And I wrote vaccines, and then I left the rest of the slide empty because we're in Florida. Vaccine is a 4-letter word here. So no, there's been a lot of, I wanted to spend a little bit time in there with vaccines, because there's been a lot of bad, social media, I don't want to say press, about all this, and we've used vaccines for a long time. You all know about cowpox and smallpox vaccines, probably 200 years, and if you go back in Chinese or Indian history, they had used some version of that for thousands of years. It's okay. There's nothing wrong with vaccines, and and they work. So you should consider it. And there's a list of vaccines. I want to talk a little bit more about sort of individual stuff. There's a lot of different kinds of vaccines which are available for various viral or bacterial infections. And there are inactivated vaccines, which are basically a killed version of a germ that causes disease. So one of the common things you'd see there is the flu shot, which you get, every year. Which that's a standard, killed version of the inactivated vaccine. Some of the newer ones, they have recombinant vaccines now, but this is the usual most common one. And then there are other subunit or conjugate vaccines where they get a piece of protein from whatever the bacteria or virus is. And then the pneumococcal vaccine, meningococcal vaccines, and all of those are subunit vaccines. There's also shingles vaccine, which is a subunit vaccine. Shingles vaccine, there are two different shingles vaccine. We probably have only one now. The original one, if some of you may remember, were available more than 10 years ago, was live attenuated vaccine. So it's a live vaccine, which is a mild shingles, and so that you do not want for people who are immune suppression. And this is a kind of a conjugated vaccine or subunit vaccine, which is much more effective when you've got 2 shots, and your risk of getting shingles is much higher when you're on immunosuppression and all that. So it's important to make sure you get all of these vaccines before, once you turn 50, that's a recommendation, then you get that so that you make enough antibodies before you start your immune suppression after the transplant. There's RSV vaccine in there, that's a newer one, which is recommended for elderly patients or anybody who are 60 or over. The thing about RSV is we were not testing for RSV in adults for a long time. We know it happens in kids, and in adults we will say, oh, you got a cold, and you get over it. But kids have a lot of RSV, especially during the winter season, and they transmit it to elderly people. If you already have lung disease, then it can put you in the hospital and make you really sick. So it's important that if you're qualified to get it. There are other vaccines, including toxoid vaccines, which is the tetanus is the most common one. You inject them with the toxin, which the Clostridium tetani, the tetanus thing produces, and so that you have enough antibody to it. So if you're infected, then you're protected. There's the mRNA vaccine, which is the newer one in COVID, and scientists are all excited. Lots of patients are not, or general public are not. It's nothing fancy. It doesn't do anything to your genetic material, even though it says mRNA. All it does is instead of giving the protein, we give the mRNA, which is the genetic material, as a vaccine, and then the body produces the protein and basically get rid of the mRNA, which it is. So eventually your own body makes the protein, and then the body recognizes it as something which is foreign, makes antibody to it, and then eventually if you get exposed to COVID, you already have antibody. That's all. It's like you have a takeout from a restaurant, or you have one of these new fancy ones where they send you the stuff, all the thing prepped meal, and then you cook it in your thing. That's all is the difference. Otherwise, there's nothing more. Of course, live attenuated vaccine. This is the one you need to remember a little bit, because if you are immunosuppressed, which means your immunity is low, or if you're even pre-transplant, we treat some patients with autoimmune diseases with immune suppression. And if you do that, then you should not take any of these vaccines. Right? There's chickenpox vaccine, which is gets to kids. The smallpox we rarely do, but MMR is still the one. The mumps, measles, rubella is still commonly used for patients who are immunosuppressed. Shouldn't get it. This is the recommendation for vaccines for patients who are transplant. This is from the Transplant Society. These are all recommended before transplant. The most important thing is to get all these before transplant. You can see it's pretty much everything is yes, except smallpox, which we don't have, and anthrax, unless there is some event. Usually it's not. And then there are some recommended after transplant, which are whenever it is, and usually your transplant team would take care of it. So the important thing is, so it's not just the patient gets the vaccine, it's the caregivers and the family, close family should also get the vaccine so that they don't get the flu or COVID and then transmit it to them, right? So remember, all these vaccines does not prevent you from getting the disease. It's basically, if you get it, then you have mild symptoms or no symptoms. So again, we talked about post-transplant infections. The timeline is highest in the first year. And that's where the immunosuppression is also higher. All those drugs may still be the same, but they try to keep the blood level of the drug much higher in the first year, and therefore your risk for infection is also higher. Can be bacterial, viral, fungal, and then a lot of times these are managed with prophylactic medications to prevent infection. As Dr. King was saying, posaconazole, ganciclovir, and all those things, and depending, all of them they have their own side effects as well, but it's important to take those medications to prevent, risk for infection, especially in the first year. Usually, some of them, may continue for a long time, but many of them usually falls off after the first 6 months or a year. So it does get better. So to prevent infection, what you do, you need to, simple stuff, all things they do in kindergarten, right? So wash your hands in soap and water, before you do something, after you do something. If you're not sure, wash your hands. So always do that. Keeps your hand away from the face, Sometimes there's droplet infection, somebody coughs in your face, it gets it. But a lot of times it's, you touch something and then you touch your face, and that's where somebody else is there, and that's where you get the infection. So you always want to keep your hands from the face, and that's what you don't want. It's also important to keep hands from other people's face too. So don't stay from other. Yeah, I know it's from last year, but we didn't have a meeting last year, and so. What did I do? Yeah, so avoid people with infection, cold and flu. Don't hesitate. Avoid situation at high risk. And the other important thing is what you're saying. Dr. King said, call your transplant people. The other thing is call. It's so much more easier. Don't think you are bothering your transplant coordinator. Have them on speed dial. Call. It's better for them to get a call and then they say something. It takes 10 minutes. Then you call the week after and say, I've been having fever for 4 days, and they're like, okay, come in now, right? So it's not good for you, and it's not good for them. So, so you want to call early and don't hesitate, right? And then take showers instead of bath, and all those things. And standing water is not good. A swimming pool, if you have a home pool, it's okay. Salt water is okay, but if it's a public pool, you want to avoid all those. Again, the risk for infection. Dr. King already talked about raw meat, raw fish, shellfish, no sushi, clean vegetables. Some people even suggest that you wash the vegetables with a light dish soap, wash it well with the soap. And that thing in the back of the freezer, no, you don't want that. And then cut flowers in a vase, you try and avoid it, but if you can't, then you need to change the water daily. If you walk to sort of any transplant ward somewhere, you would see the nursing station. They have a nice, pretty flower vase with flowers and all that in the nursing station. It's not like anybody likes the nurses. It's all sent to the patient and says it can't get into the room, so it sits in the nursing station. So avoid all those. We don't want standing water, water features, fountain, all those things. because it can have bacteria in there. Gardening, don't do it. All right, that's my Apple reference to the garden. In case you didn't pick it. Right? Soil has a lot of bacteria and fungus, and you want to avoid it. Right? Don't do any indoor plants, indoor soil. Right? Pets, you already talked about. Dog and cats are okay, but don't clean up and don't change the litter box. Avoid things like reptiles where they have a lot more bacteria in there. No birds. There are some transplant centers who tells you beforehand that if you have a bird, we will not transplant you, period. So this is a nice picture. This is from Rembrandt, right? So this is a storm in the Sea of Galilee, and you can see this bad storm. People are holding on to life, and I think some people are trying to throw up. And if you see right in the middle, if I can see it there somewhere, you see there's a calm Jesus there. So sometimes post-transplant is like that, right? You need to have some faith. You need to have some faith in whether it's faith sort of religious or in yourself or in your doctor and the team and everywhere. You need that to weather the storm, right? So you all have seen this in cheesy, Hallmark cards, right? The ship in the harbor is safe, but that's not what ships are built for, right? You get a lung transplant so that you can go back to somewhat life, it's normal, right? There's no point in getting a lung transplant and staying in your bedroom to be safe. But for that, you need to try and follow some rules as much as you can, have faith, and then get through the storm. Yeah. So if there is something you're not sure, doubt, this one always works. So what you do is you extend your arm. You can do it for me. You can do it. So extend your arm. All right. Make a fist. All right. Extend the index finger. Index finger. And then point to the next guy and walk away.
I do have to say that I'm speaking today as a caregiver for Annie, not as an employee of the University of Virginia Health System. Real quick, so my journey to transplant caregiving, so as you heard, Annie received a bilateral lung transplant on March 19th of 2017. 9 years approximately prior to that, she'd been diagnosed with pulmonary fibrosis. I believe actually a transplant was mentioned at the time, but it was a little bit shocking. It was like, oh, that's got to be so far away. We're never really going to have to think about that, are we? And in many ways, her course, she was a very kind of positive outlier. She did really, really well for a long time. Seemed to be well, her PF was well controlled by the medication she was taking. Never had to use oxygen until about 2 years prior to this time. Then all of a sudden, there were some changes. So she was a nurse practitioner in psychiatry, had an inpatient-outpatient practice that she did for almost that whole time. Eventually started doing it from home so she wasn't exposed to the infections of being in an office with some folks that had less than perfect hygiene, shall we say. And so she did that, but eventually it came time for her to stop doing that and time for the evaluation for a lung transplant. So we thought that, given she'd been very driven to do all the things were important, stay active, stay in good shape, we thought this is going to be, she'll probably be a positive outlier. Our journey will be on the smooth side from some of the stories we had heard. I think probably one of her major concerns was prior to her transplant, I had no interest whatsoever in being involved with a medical system or anything having to do medically. If something came on the television that had to do, I would typically turn my head because I was very squeamish about those things. I'm guessing she had very real concerns about both my willingness and my ability to perform as a caregiver. But we seem to have gotten through that. So, but neither the pre-transplant portion or really the post-transplant portion went kind of in the dream scenario that we had created for ourselves. And I called it a journey, and that's why I picked this photograph here. So used to be when we'd go on a trip on a journey, a couple of backpacks, a few things. I believe this is a photo from the hotel room when we were having our final evaluation at UVA for the transplant. We've got our concentrator there, our home fill system, a whole bunch of bottles. All those things had to be in our car as we traveled down the 2 hours down I-81. And we'd never really thought about it before. Many times we'd traveled on I-81 and thought, yeah, and there's these horrible backups there. All of a sudden we had to think, now what happens if we're in a 4-hour backup on I-81 and we don't have enough oxygen anymore? So interesting things. Anne was listed, I believe, in July of 2016 at the University of Maryland originally. And we thought, yeah, 3-4 months, I'm sure we'll get the call. We're getting ourselves all prepared. Had 2 dry runs during that period of time. One of them, she got all the way back to the operating room. I believe that was the time we were doing the lung in a box thing. And they decided eventually the lungs had not perfused correctly and decided not to. Actually, we were really, really happy about that because it said to us, this team is not going to do anything suboptimal for her. A little disheartening to have, be called down, think it's going to happen, but then it didn't. And then eventually we discovered that we could double list, and we also listed at the University of Virginia. Had 1 dry run there, but eventually on the 19th, it happened for real. So, talking to you now as caregiver. So, in the hospital, Anne made me promise to take a picture of what she was like coming out of it. I didn't really want to do it, but here it is. She said I could use this. It's a little hard to be prepared to see your loved one unless you've had a lot of other surgeries like this. Anne actually had never had any surgeries of any kind. She delivered 2 children without as much as a Tylenol. So this was like, she decided to go big the first time around and have a bilateral lung transplant. So just seeing that there. So since I joined, actually have done an improvement project where we tried to figure out how many of those IV channels does somebody really need. And so I went back and said, I got this picture, and there's 11 there. So she had 11 IV drugs running all at one time the day she came out. Everybody's journey is going to be different. It's really, really hard to know. Again, we thought, she worked really hard to be in really good shape. Probably be one of those people, 2 weeks, we'll be done, we'll be out, and we'll start on that. Since it wound up being 28 days in total, 2 weeks in the ICU, 2 weeks in the step-down unit. Some of the complications that these gentlemen have talked about did come home to roost a little bit, but it all worked out. But since she started mentoring other lung transplant patients, since then, we know people started eating solid food after 5 days. She got, after 17, we had this board where we charted milestones. After 17 days, she was allowed 1 ice chip per hour. And she was like, what? You got food after 5 days? And they were out after 7 days. It didn't quite work that way for us. So it's going to be different. And it's hard to know. You can prepare as well as you can, but things are going to happen. You just saw like lists and lists of all these things. And some of them might happen. As a caregiver, you're going to need to be an advocate. So if you are at a hospital that is a lung transplant center, you are somewhere where there is a team of incredibly talented and dedicated professionals who are going to do absolutely everything they can. But they can't be in that room with you 24 hours a day either. They know all the technical, clinical things that could possibly happen, but they don't know your loved one either. So they don't know when he or she is making that face, it means there's something seriously wrong, and you need to be able to share that with them. And in all honesty, the workforce situation in hospitals these days is challenging, and it continues to be. So Many, many hospitals continue to work with workforces that are not their permanent workforces anymore. People are on contracts as travelers. They may not be quite as familiar with all the protocols, so it's really helpful to be there and be able to be someone who can reference what you've heard, what you've been told. But I think you'll find that while it's going to be challenging, it can be something of a rude awakening to see your loved one in a state that's so different from the way that you may have experienced them for 20, 30 years. Knowing that they have received this miracle of a new start on life will be a strength that will carry you through. There's going to be some other things, too, that you probably will discover. So I think for the first probably 18 to 20 days, until they got Anne's trach valve just right, she couldn't communicate verbally. And during that period of time, we learned I am a horrible lip reader. I cannot read lips to save my life. And her handwriting, based on some of the medications, was some alphabet that has never been seen on the planet Earth as of yet. We got her a whiteboard. I don't know what she was writing on there. So we had a really hard time with that. But eventually, it all worked out, too. So you do eventually get out of the hospital, and that first year, it's going to be a balancing act in many, many ways. So at the top there, I've got some of the new things, so a spirometer, a pickle, probably there's a nebulizer there somewhere, probably some of the antifungals that I had to learn to give her for a little while till we made sure that wasn't going to be an issue. But then down below there, that's Anne out on the track at UVA. I think she was getting prepared for for something a goal that she had set to do the women's 4-miler that we have in Charlottesville. There's going to be steps forward and steps backward, and that's why I said X steps forward and Y steps back. It's really hard to know what they're going to be. You may be fortunate and maybe 10 steps forward to 1 step back. It might be 2 steps forward to 3 steps back, and it's going to change over time. But I think you just have to be prepared that it's rare that's a linear, get better and better and better. Things are going to crop up. So she did, one of the things, and a good example of that, I think, is Anne did do that women's 4-miler. So just slightly less than 6 months after she had her transplant, didn't run, but walked that 4-miler in freezing cold, rainy conditions. It was just horrible that day, but she did it. And then I think a little less than a week later, had a routine bronchoscopy and was told, you're in rejection. How could that be? How could that possibly be? Go from that high to all of a sudden that seeming low. Got it under control very quickly with some IV therapy, and we were back on track. But so things are going to happen like that. I got there, and you've heard this from both these gentlemen too. The transplant team is not kidding when they say, call us, no matter how small or how silly it may seem to you. So last year for Christmas, one of our transplant NPs is a gentleman named Sean. He's been our constant all the way through. He's the one who Anne always contacts. She put together a Christmas card. There was a summary of all the MyChart messages that she has sent him over the year, and it was 2 full pages of things like, am I allowed to eat miso? Does this mole look funny to you? Can I get a puppy? Can I go hang gliding? Just a whole list of things that poor Sean has had to deal with good grace over the year, and he has always done so. And some of them turned out to be really important. The one other thing that I'll say about the first year is it kind of amplifies your loved one to some degree. So whatever their superpower may have been, so for Anne, it was kind of setting goals and achieving them. I mentioned some of those. She's going to talk about some more in her session tomorrow, but and so that can be challenging. I really want to run up this set of 82 stairs and have you video me multiple times. And so we did that. But every person with superpower probably has a kryptonite, too, that you need to be prepared for. So Let's just say hypothetically, having nothing to do with anyone that may be in this room right now, but if they struggle with math word problems, the expectation that they can solve the problem, if I need to take 2.5 milligrams of tacrolimus in the morning and 2 in the evening, do I have enough pills in these 2 bottles to get me through 2 weeks? Probably isn't going to happen without some support, and they're going to need you for those things. Last but not least, so you are going to be in a new normal. So somebody who has gone through a lung transplant, they just have to be a different person. It's such a life-altering experience in many ways that it's something that you're going to need to think about. There are going to be a list of many things you can no longer do. These gentlemen have listed some of them. I will say, if you are a big fan of pomegranates and blood oranges, for some reason, you're not going to be able to have those anymore. I don't know why. They can tell you the chemistry, but we just knew that we couldn't do that. It does become, and you've also heard a lot about this balancing act. The way that I've come to think about lung transplantation, certainly, is we heard Dr. Bonham in the session in here last time say, it's not a cure. You have started down a different path. And I've come to think of it, you have agreed to engage in a lifelong game of hide and seek with your own immune system. You're trying to hide the fact that you've had a new organ placed in your body, and the medications they're going to give you to help you win that game are going to cause some things that you're going to have to try and manage as best you can. And it's something that you are going to have to experience. But there's also going to be a list of things you never thought you'd get a chance to do. So that top photo is Anne's 6th lungiversary, where she climbed McAfee's Knob on the Appalachian Trail. Took that picture. I was scared to death. I'm afraid to death of heights. I would never get out there, but I did take that picture. So there are going to be these things that are just amazing that you never thought you could possibly have experienced. I will encourage you to never forget to honor the miracle that you've been given. You need to figure out what that means for you. So my wife has had the opportunity to be a PFF ambassador, to be a mentor for lung transplant patients, both pre and post at UVA, and try and give back that way. You will find your own way to do that, but also every day just realizing that some of the things that I'm asked to do based on the contract that I have with my transplant center are things that maybe I would prefer not to do. You had agreed to do that in exchange for that gift that you've been given. I forgot to mention in many of those scenarios before, as a caregiver, it's really important that you take care of yourself. There are going to be times when that person is in the hospital and it's a challenging scenario. Being in that ICU for that length of time can wear on you, so you need to find a way to take care of yourself. In that first year out, use the support network that you have. So if you have a network of friends and family who are willing to come and do things for you, you do not have to do it all yourself. And then eventually, once you reach this new normal, you need to be prepared to take care of each other as you move through that new stage. You saw the curves about life expectancy. That may not have been the life expectancy that you were necessarily hoping. So having the conversations about, well, what will that mean for us, later on? We talked a little bit in the last session about it's probably good for you and all of your family to think about doing something like we just sat down and completed the 5 wishes document for both of us recently to tell people what we would want eventually at the end of our life. But having the opportunity to be a caregiver for a lung transplant patient has brought about some incredible changes in my life. For some reason, I now work at a hospital every single day. It's really strange to me that I have agreed to do that. I've had an opportunity for my wife to move back to her hometown, and we've had almost 7 years of additional time together that have just been amazing. So thank you very much.